Hello, everyone. Good afternoon or good morning, as the case may be. My name is Joe Burns. I'm the beat leader for health reform and health insurance here at the Association of Healthcare Journalists. And our webcast today is one in a series of webinars for healthcare journalists seeking story ideas and resources they can use in their work. So thank you for joining us on the pressing topic of how healthcare prices are harming employers and families. Our two speakers are Cora Opsahl, who's the director of the Health Fund for the Building Services 32BJ Labor Union in New York City. This union has 210,000 or 211,000 members, a lot of members in 11 states. Our other speaker is Gloria Sachdev. Gloria is a Pharm.D and president and CEO of the Employers Forum of Indiana, a nonprofit that seeks to improve the value employers and consumers get from what they spend on healthcare. So on those issues, we'll begin with Gloria, but I just want to say that Cora will explain when we get to her that over the past 10 years, U.S. workers' wages have risen 54%, while healthcare prices have gone up over that same period 230%. So putting that in other terms, Cora will say that what consumers spent on healthcare 10 years ago represented 17% of workers' total compensation, whereas today it represents 37% of workers' compensation. In other words, rising healthcare costs drive down or contain workers' wages, which is part of what Cora will explain when we get to her. Gloria will show that what the Employers Forum and other employer coalitions have done is to fund research over the past 5 years, since 2019. Is that 5? Yes. 5 years funded multiple rounds of research with the Rand Corporation into how much employers have paid hospitals compared with what Medicare pays for the same services. So the most recent report came out in May, and I'll post a link in a few minutes. The most recent report came out in May from the Rand Corporation, and it showed that employers pay 254% more than what Medicare pays for the same services in U.S. hospitals. So that's a big boost over what Medicare pays. And as I said, I'll post that link. So Gloria and Cora will talk today about how they use data, such as the Rand reports, to negotiate lower prices from hospitals, and hospitals, not surprisingly, push back. So we're going to begin with Gloria. She's going to explain what's going on in Indiana, but also nationwide, because that 5 years of reports started in 2019, but it was first year was Indiana, and then it was 25 states, and then it was 49 states, all but Maryland is included. Maryland has a global budget, so it's a little different, so you can't compare apples and oranges, as we know. And then we'll turn to Cora, and she will give us a great case study. And then we'll go back to Gloria, who can explain what tools journalists can use in reporting on hospitals in their cities and towns. So Gloria, we'll begin with you and your slides. Please, thank you very much.
Thank you, Joe. Look forward to having a robust discussion here, and we will have plenty of time for questions. So I'll go ahead and share my slides. Okay, are my slides full screen?
Yes.
Excellent, thank you. So a little bit just so you know who I am and who the Employers Forum of Indiana is. We are an employer-led healthcare coalition that was founded in 2001. Our board and our executive committee are only employers, so they are not providers, TPA, insurance companies, but self-funded employers. We are a 501c3, and our goal is to improve the value employers and patients receive for their healthcare expenditures. We are, the 3 legs of our stool are education. We have all stakeholder meetings. We have employer-only meetings. We have various initiatives. I'm going to talk about both the RAND study that Joe mentioned, plus some policy initiatives that we've been involved in. And there's our website. We post almost everything online. We really want this to be available for the greater good. Now, while we're the Employers Forum of Indiana, at the very bottom, I have a link. It's for the National Alliance of Healthcare Purchasers Coalition. There's someone like me in almost every state. And so some states have multiple business coalitions. So I would encourage you to go to this link and if you're interested in looking at seeing if there's a business coalition in your community. Not all the business coalitions belong to the National Alliance, but the far majority of them do. So as Joe mentioned, the problem that we have is that the cost to the employer and employee is going up year after year after year after year. So this is from KFF, and it shows from 1999 to 2003. The dark blue is what employers are paying, and the light blue is what employees are paying. And so now what we have is in 2023, $24,000 for family coverage and insurance premiums. This is money that's coming out of employee paycheck. So this is about $500 a month, a little over $500 a month. People are paying for premiums. And here, what you'll see is, in addition to premiums that have gone up 314% over that time period, workers' contributions, because we have switched over in a large sense to high deductible health plans. So in high deductible health plans, like for myself, my deductible is about $4,000 before my insurance even kicks in. And then there's this co-insurance, which is, okay, it's a maximum out of pocket, but that difference is the co-insurance. And I pay 20% and my insurance pays 80%. Until I hit a max of about $8,000. I actually have pretty decent insurance. A lot of those numbers for folks are $10,000, $15,000 max out of pocket. The issue is that overall inflation and workers' earnings have not kept up. So more and more money is coming out of people's pockets. And it really has detrimental consequences, both to employers and to employees, as we'll discuss.
Gloria, let me just ask you a question about that slide. Can you just go back to it for a minute? So $24,000 every year. Well, that's what it was last year in 2023. That's equal to a small car, right? And who buys a new car every year? Not many people. And I have some neighbors, I think, that do, but
not me.
that's
Mine's
a
a
lot.
2012.
Yeah, right. My car is 2015. So
Yeah.
that's a big expense, in other words. So I interrupt. I just want to put it in context a little bit.
It
That was
is,
the point
and
KFF
I
made.
think that's really important to understand. It's not like wages are going up, just a bigger chunk of the employer's budget and the bigger chunk of employees' household budget, if you will, are going towards paying for premiums. But then they have, as this shows, not just premiums to pay out of pocket, there are other worker contributions by way of co-pays, co-insurance, high deductible health plans. So when I first started this job 9 years ago, and as I'm a clinical pharmacist by background and training. I worked in primary care physician offices for 12 years, managing patients with chronic diseases. I had no insight to prices like doctors that are seeing patients do. We just don't know. You might see, I don't know, 20 patients in a day, and everyone's got different insurance, and you don't know what's covered by what insurance and what the copays, and you just have no insight to that. People don't know that necessarily either. And so there's this, all of this I feel is somewhat intentional. All of this is available. It could be made more available. And one commitment of the forum is to bring more price transparency and quality transparency to the forefront. The way we started doing this was back in 2016. I started this job in 2015. And when I met employers and asked them, what's your biggest pain point? All of them unanimously said that it's healthcare costs. It's unsustainable. We're going to hit a wall. And I will say now that 9 years later, we hit that wall. That wall has been hit. And we have more people in medical debt than ever before. Our outcomes are worse than they used to be. People aren't accessing care because they're afraid to access care. And businesses are not as competitive as they were in the past.
And I just had a point about that because that unsustainable term, I've been covering healthcare since 1991. And that term was used then. And so here we are 30 something years later, and it's still being used. And every year, a lot of people said we can't keep doing this. That's what unsustainable means. And I agree, we've hit a wall. But well, we'll see what happens next year, right? And sadly, I hate to say, but prices will still go up. So I've interrupted, and go ahead.
Yeah, prices will likely still go up, but there's a lot of variation in prices. And so if we have price transparency, we have it. We just need to get it in a more usable form. We can start making more informed decisions, both informed policy decisions and informed
Mm,
purchasing decisions. So
mm,
we did come up with an idea of saying, I wonder how much, when I would meet with hospital CEOs, and say, well, the employers are saying the prices are high based on their own claims. They would say, well, our patients are sicker. We can't make it on Medicare and Medicaid alone, and we have to cost shift to employers. And we're not the only ones that do it. Everyone does it. So that's the impetus for doing this study, was to see, how high are the prices? What are commercial prices as a percent of Medicare? Medicare is the benchmark because Medicare uses one formula to pay all hospitals, all community hospitals, the same way, which are acute care, normal hospitals, not long term care, psychiatric care. Critical access hospitals have different formulas. And so this was a way, and it takes into consideration Medicaid, Medicare, if you're an academic medical center, how sick the patient is. So it's a great benchmark. And in 2017, we published our first study, as Joe mentioned, and then we've been doing them every about 2 years now. So the latest one, I'll just skip to this last column. It says PT5 is price transparency round 5, or sometimes I call it RAND 5.0, and it has hospital facility inpatient outpatient fees and what the doctors get, which are professional fees. The doctors on the inpatient outpatient side, it's 49 states plus DC. It's 2020 to 2022. We started with 120 hospitals in Indiana. We're up at over 4,000 hospitals now. And, we got millions of claims that are being analyzed. And these are not charges. This is actually what employers and people paid. It's the receipts. Okay, this is what was paid, not posted in machine readable files. It's about $77 billion in healthcare spend. Right?
77 billion. Wow, almost $80 billion.
Yeah. So my computer seems to have frozen.
No.
I know. I'm just going to stop sharing and then reshare. My apologies for that technical difficulty. Okay. No, it does not want to. This one slide, it just wants you to look at it more. So let me get back to this and try one more thing. I might just not have it in presenter mode and see if that works. I can't understand. Okay, I'm going to have to manually do it. It's stuck somehow. So what we found was, because we looked at 49 states plus DC, is you can rank all the states. And Indiana is 8th highest at 295 or 297% of Medicare. This is what commercial prices are as a percent of Medicare. So we're paying 3 times what Medicare is paying for the exact same services at the exact same hospitals at the same time. And this is all in inpatient plus outpatient hospital facility and what the physicians are getting. What are and you can kind of cut the prices out however you want, but I'm just showing 2 slides. That was the total. And then this is just inpatient, outpatient, professional. So here you can see in Indiana that our physicians are getting paid fairly low. What does this lead to? It leads to the big hospital systems that are really getting overpaid on the commercial side, buying up our physician group. So in Indiana, most of our physician groups are employed by the hospital systems. We have some that are also employed by insurance companies and by private equity firms. So our market solutions that we've been looking at are really important. We have employers that are paying attention, and Cora's in New York City, and she's definitely one of those employers around the country that are paying more attention to this. And the part of the reason is employees are suing their employers. I'm going to say that again. Employees are suing their employers for not meeting their health plan fiduciary duty under ERISA, which is a federal rule. So Johnson & Johnson was the one that came out in February, where employees of Johnson & Johnson were suing them for not meeting their fiduciary responsibility of all things drug costs. And more recently, Wells Fargo was sued by their own employees. And it's a class action national suit. I get calls from attorneys all the time. They are literally circling the wagons. And this is from State Farm, this is Target, this is that particular attorney group. Some of you may want to call them and see, if it's resulted in any actual any actual lawsuits yet. This is Lockheed Martin. They have this whole advertising where, do you qualify to be part of this class action? Click here, and you can just put your name in and be part of the class action. It's just really a different time, and it's eye-opening for employers. So questions for thought are, given that employers under ERISA have this fiduciary responsibility, they need to start thinking in terms of this. So as you hear the rest of this presentation from Cora and myself, I would try to keep these in the back of your mind as framing questions. Are employees getting healthcare services at the best quality at the best price? How do they know what's the best quality at the best price? That's difficult to ascertain, and employers have a responsibility to steer them and have in their benefit plan best quality at best price, not worst quality at high price. That sets them up for a legal lawsuit, because there is more transparency now. And so they need to look at it. So they need to own their own claims data. They need to understand their data and use their data. And I added this one more recently. They need to document themselves to protect themselves from these lawsuits. And as a fiduciary, you should document anyway. And the reason is, if you're picking maybe a higher price facility, there could be a really good reason. It could be because it's convenient, closer access to care. It is their quality for the claims that you primarily send to them. So employers need to document all that. In the market, what we're seeing here is employers are sick and tired of relying on the insurance companies to negotiate their rates, because they're not doing a good job. I told you in Indiana, it's 300% of Medicare, and the national average is 254. So they are more and more in these last few years getting involved in direct contracting. The employer is directly contracting with a potential provider for orthopedics or cardiovascular procedures, and they may hold multiple direct contracts for labs and images and things like that. They may contract as a bundled payment or as for centers of excellence, which is what COE is. Some of them are engaged in narrow networks or tiered networks. We're putting a lot of pressure on the insurance companies to develop. If you have a network, which means all the providers are in network, then they have no incentive to compete on price or quality. If you had a tiered network where the best quality at the lowest price was kind of like in a wedding cake, if you will, that the top layer, and then a middle layer and a bottom layer, you could design your benefits to encourage people to go to the top, where they may have no out-of-pocket expenses if they pick tier 1, for example. Everything needs to be data-based, and it's ridiculous to just rely on the vendor that's providing the service to do your analysis. You really need to use an independent vendor. I mean, if I ask Anthem to do a report on how well they're doing for me, you can bet their report's going to be fabulous. Now, sometimes they will say, well, we won't charge you, but if you want access to your data to have a third party do it, we're going to charge you $2,000 a month per person. And employers are like, what? I'm a school system, or I'm a city. I don't have that. Fine, you do it. So we did pass a law recently that said they can't charge, at least for one big audit per year. This is a big one. It has to get past a selling game. There are so many apps and digital features and vendors that are out there. Everyone's trying to sell their solution. The benefits, the pharmacy benefit managers, the TPAs, the third-party administrators, everyone's got something. So they all need to have skin in the game. They can't just go to an employer and say, hey, this will reduce your cost by 20%. And what if it doesn't? How many employers, why should they take 100% risk when their advisors are advising them poorly? So there's an opportunity there for them to help taking on some fiduciary responsibility. So that's market. I could spend all day talking about market, but I'm going to switch gears here a little bit and talk about legislative policy. Because the market has generally refused to change, we've had to get involved in policy, and legislators have come to us. So in Indiana, our House Speaker, the Speaker of the House, is Todd Houston, and the Senate President Pro Tem is Rod Bray. And they sent letters to all the big hospital system CEOs and the two big insurance companies that we have, Anthem and United Healthcare, in 2022. And there are links to these letters. And in the letters, it said, you need to get your prices, work together, get your prices to the national average. And if you don't, by 1/1 of 25, we're going to do it for you. Okay, well, 1/1 of 25 is in a few months in a new session. So we're hoping that because our prices are still high, but way above the national average, that we are going to implement really significant policy to reduce prices.
What's the national average, Gloria? That would
254
be the
and
target?
yeah, 254 is the overall target, but you can look at targets in different ways. You can say, I want to look at the hospital target, I want to look at the physician target, because when we look at Indiana, well, it's 297 altogether, and I can show you on Sage Transparency how you see what the hospitals are getting, and then what the national average is on that, and then what the doctors are getting, and what the national average is. So we've been asking, requesting, demanding that the insurance company start paying the physicians more in our situation, and pay the hospitals less. And then we prohibited non-competes so that we can increase competition in our marketplace. There are lots of strategies that
No.
I
Oh,
know
there you
that's
go.
like a were you
That's
gonna ask
really
a question?
fascinating because I thought the 254% was a whopping number, but what you're saying is in Indiana, you're paying 297, almost 300%, and that's even bigger. So that's why. So if you can just bring it down to that whopping 254,
Yeah.
you'd be better off. Of course you would be, but that's still
No,
very,
we
very
would
high.
be. We
You
would
also
be
mentioned
better
that
off. Yeah, and we have
you.
some hospitals that are charging 400, 500% of Medicare. And
Oh, I see.
they're monopolies in their community, and they can charge whatever they want, and that's not
Yeah.
fair. And these, Indiana, our socioeconomic status, our cost of living index is 0.9, which means we're below 1, which is the national average. So our cost of living, that makes sense. Indiana cost of living should be lower than certainly where Cora is at. But our prices are through the roof, and the income level is lower for the average household here as well, but their prices are through the roof. More and more money out of pocket for themselves. So I will say it takes a team to get anything done across the finish line. The media was so helpful. I posted a slide deck on our website under policy. Just from last year, there were 167 news articles just in a 4-month period. They were covering it. And over here is Rod Bray and Speaker Houston. These are different committees. I go in and testify. Employers are testifying. And this is the first time these legislators have heard from employers. Usually they just hear from the industry.
Well,
So
that's really that's terrific. And what you're saying is that journalists are covering the story. It sounds really well in Indiana, but your effort, your nationwide effort, is kind of based in Indiana. So I'm hoping that journalists in all the other 48 states, and Maryland's the outlier, will do the same, because hospital prices affect everyone. They affect health insurance prices. They affect wages, as we're seeing. So that's all huge. Were you getting to the end of your presentation? I didn't mean to cut you off.
Yes. So I just wanted to say that we have been successful. And I just want to say we've been doing this for about 4 or 5 years. The media's come with us. They're so important for op-eds. They're so important for just as a nonpartisan. They talk to people, constituents, and that's helped get these laws across the finish line. We really, frankly, couldn't have done it without educating everybody about it. So these are a couple of things we did. We eliminated hospital facility fees for off-campus. So you see a lot of hospitals buying up everything in town. We said, if you're not on the hospital campus and just because you bought it doesn't make it a hospital, and you can't charge a hospital facility fee for it. We did quite a bit of work on non-competes, and we set a benchmark for 285. Last year, we made sure that employers own their own data, that they can do unfettered audit ability. You would be surprised how many TPAs, PBMs are trying to restrict them from accessing their own data. We wanted to get spread pricing, like just prohibiting spread pricing. That bill that language made it into a bill, but it did die. We'll bring it back. We did get mergers and acquisitions, now have to go to the Attorney General's office for monitoring. So we're small. We don't have 100 lobbyists. We're fighting like an army of lobbyists from the hospitals and the PBMs at the State House. So these aren't very expensive. They're advertising trucks. And in the newspaper, you can see there's Hoosiers for Affordable Health Care. They are, I'm on their board, and that group does more of this advocacy, but it's been really helpful. I want to talk after Cora does a little bit about Sage Transparency. It's a freely publicly available hospital price quality database, and you can see how hospitals are doing nationally at the state level, benchmarks in different regions. Just a little bit about Sage Transparency is comprised of 5 different data sources. I'll get into those when I go over it. I was super excited to see that Indiana launched after 4 years. We passed a bill in 2020. They just launched a state all payer claims database, and it has actual prices. You can pick the plan. I mean, you pick the procedure, you pick the plan, you pick like what insurance you have, and you pick where you live and how many miles you want to drive from, and then it shows you what the options are, and it shows you some price and quality. So I put a demo link in there if you guys are interested. So that's all I have for right now, Joe.
Thank you very much, Gloria. I'm sure that that our members will be very interested in seeing how the Sage price transparency tool works. So when we get to that, you'll go back and explain. I just wanted to point out that this webinar is 2 housekeeping things I forgot to add in the beginning. This webinar is the first in a series sponsored by the Peterson Milbank Program for Sustainable Healthcare Costs. The key there being sustainable healthcare costs, since there's so much talk about unsustainable. The other housekeeping item I wanted to say is if you have a question, any viewer, any one of you can add a question to the Q&A, not to the chat. The webinar chat is a different thing. So if you add your questions, we'll find them in the Q&A. So please do that. So our next speaker is Cora, and she has a terrific case study about what's going on in New York City and the other 11 states where you're working. So go right ahead, Cora.
Great. Thank you so much. As always, I love listening to Gloria talk and kind of talk about really in a lot of ways the beginning stages of where we started. And I will say it's because of the work that Gloria did with RAND 1.0 that really is what started in parallel to a lot of the journeys that 32BJ Health Fund has done. So I want to share a little bit, bear with me as I pull this up. A little bit about 32BJ, and we're going to call it a case study because I think Gloria really laid out the landscape of I think we were talking about the unsustainable nature of healthcare. And so we at the 32BJ Health Fund have taken we'll call ourselves an activist purchaser position when it comes to how we want to think about healthcare. So before I get into all of that, I do want to just spend a little bit of time and tell you a little bit about who we are. Some of you have probably never heard of us, and that's okay. I'm glad now by the end of this that you will know who we are. So 32BJ Health Fund, we are a self-insured multi-employer Taft-Hartley benefit fund, and we provide health benefits to over 217,000 covered lives of union members of the 32BJ SEIU union. They are the largest property service union in the country. It is cleaners, property maintenance workers, door persons, security officers, windows cleaners, building engineers. We have school and food service workers, and including airport workers. So if you've flown through JFK, LaGuardia, or Newark, you have probably, the baggage handlers and things of that nature, the wheelchair pushers, you've talked to a 32BJ member. If you've ever come to visit New York City, you have talked to a 32BJ member. We are jointly governed by both the union and the employers. So I am responsible to the members and to the funders, which is the employers. And we have premium free healthcare to the union. It is 100% paid for by the employers, and it is contributions from over 5,000 employers that fund these benefits. We provide high quality benefits. We have no monthly premiums for members. We have zero in network deductibles, low in network copays, and we have, for a large portion of our population, free family coverage. And so if you think back to Gloria's slide that talks about the rising cost of the worker components of healthcare, our union members are able to access high quality care for very little cost.
So I'm sorry, Cora. I have to ask. I think you said that your members, the 217,032 BJ union members, don't pay a premium, don't pay a copay, and have low. What was the other thing? I mean, those two numbers right there are staggering because most
Mhm.
people have to pay a premium plus a copay and co-insurance, as Gloria said.
Correct. So the benefits are 100% paid for by the employers. So of our 5,000 employers, 100% pay for health coverage. And that means our union members have no monthly premiums. They have no in-network deductibles, and we have low to no copays for their benefits. And we've
Mm,
done this, Joe, in part because of the way that we've been able to leverage data, as Gloria was talking about, to really drive innovation and save money for many years. Um,
mm.
and this is because, let's look at the numbers, right? So let's go back to talking about the numbers, because in the end, we live and die by the data. We can look at over the last 10 years, wage increases have gone up 54%, whereas healthcare costs have gone up 230%. Healthcare as a percentage of total compensation for our members have gone from 17% to 37%. So again, every dollar that's spent on healthcare is a dollar that cannot be spent on wages and other benefits. And had
So the five.
healthcare,
Go
yep,
ahead. Yeah, go ahead. Go ahead.
I was going to say, and had healthcare increases gone up at just the rate of inflation, not at the rate of healthcare increases, our members would have had more than $5,000 in annual wages in their pocket. That is food on the
Five thousand
table.
dollars. Five
Yep,
thousand dollars per employee per year.
correct.
So that's huge. That's like getting a big salary bump every year.
Correct.
$5,000. Who wouldn't take
Yes.
that?
Right.
Okay,
And
thank you.
so, yes. So this is why we talk about this, right? Because and I think the unions are uniquely positioned to truly understand, and union members to truly understand total compensation. But this is true regardless of the employer, whether they're a union member or a for profit company, healthcare is continuing to take up more and more of total compensation. And now, when we talk about healthcare, we think about it a lot. We say, okay, well, what does this mean? And so I like to use this graph because it really shows that when we talk about healthcare, what you hear about all the time in the news, and as you know, journalists, I'm sure you've heard all of these things, is that, oh, you know what's driving it? It's drugs. Drugs are driving this. But since 2009, drugs cumulative rate of inflation has gone up 30%. We're like, okay, well, you know what? It's insurance costs, it's medical care, but that's gone up 50%. But what has gone up, and I think, and this is through 2022, is hospital costs have gone up 80% since 2009. And actually, if you look at the graph, I think through 2023, it's gone up about 90% in that time frame. That hospital prices are is what's driving the increase in costs right now.
That was a
Hence my next slide. See, like it just flows together. We talk about hospital costs are driving employer costs. For us in 2019, we knew that we were spending about 44% of our dollars are spent on inpatient and outpatient hospital costs, which matches the Center for Medicare and Medicaid. Also says on average, every employer spends about 44% of their healthcare costs on inpatient and outpatient costs. I will tell you, we've recently redone this data, and our number is now close to 52%. 52% of the dollars we spend on healthcare go toward inpatient and outpatient hospital costs. And so,
wow.
as this continues to take up more, we recognize that we have no choice but to do something different. And we started by looking at like how do we do something differently? And we started by saying let's go to the data. We have been really fortunate that we have had our claims data for over almost 20 years now. And we started looking at our claims data a few years ago, many years ago now, I think in about 2016, and we started saying, huh, this is weird. we're spending such wildly different prices for the same simple procedures depending on where you get your healthcare done. And so when we look at this, we're looking at this, okay, using a colonoscopy, because a colonoscopy outpatient, taking out the outliers, a colonoscopy is a colonoscopy. And we were seeing that at New York Health and Hospitals, which is the city hospital system in New York, we were paying about $2,200 for a colonoscopy. Meanwhile, at New York Presbyterian, we're spending over $10,000 at for a colonoscopy. And so you have to ask yourself, is a colonoscopy worth 4 times what you're paying for when you just switch hospitals? And so we looked at this, we looked at a hip replacement as another example, which we know is expensive. Hip replacements are expensive. And this is one of the reasons that, employers look at different ways to solve for these problems. Is we said, oh, New York Presbyterian, we're paying $83,000 on average cost for a hip replacement versus everywhere else on average we paid $58,000.
Oh.
And this data we were able to get just through using our claims data. And it led us to make some different decisions. It led us in 2022. First, we tiered our network in 2019, and we tiered based on price. And Gloria talked about the wedding cake kind of thought process of like the highest quality, lowest cost, the mid tier. We tiered it by two. We did 2 tiers. High priced hospitals were non-preferred. Low priced hospitals were preferred in New York City. We're really fortunate. We have 5 academic medical centers, a city hospital system, and safety net hospitals. I mean, I think you can throw a rock and hit a doctor at any corner. We've got plenty of healthcare. So we tiered this in 2019, but in 2022 we ended up removing the most egregious high-priced hospital system at the time, which was New York Presbyterian. We removed New York Presbyterian, all of their hospitals in all of the New York City boroughs, and all of their affiliated physicians. And what it was able to do is we saved $33 million in 2022, which resulted in a negative 4.5% trend. And now in 2023, we had a flat trend. We've saved, by the way, again, another $33 million in 2023, because this savings is just from members getting the same care at a lower priced hospital system. That's it. We didn't see reduction.
That's just from negotiating with hospitals and saying, look, we have the data. And listen, I've never heard of an employer saving a 4.5% in trend. Cutting your employee benefit cost by 4.5%. I mean, maybe it's happened. Of course it has, but that's very, very unusual. And then to have the next year flat trend, everybody else is paying whopping increases every year. So good for you. And how did you do that? By just negotiating hard?
No, by removing them from the network. This was not a direct contract. We just removed them from the network, which, let me be really clear, is very difficult to do because of the contracts that exist between the providers and the insurance carriers. And we'll talk about that in just a moment. But I want to talk about the savings piece, because oftentimes that's what people get. We get starry-eyed about the $33 million and a negative trend, but we were able to take this savings plus other benefit designs that we've been able to do and leverage that, allowed the union and the employers in their contract negotiations to ensure that give that savings back to both the employers and the union members. It resulted in the largest raise in contract history, a one-time bonus for all of these members, and employer premium increases for 24 and 25 will be 3% and less than 3% in 26 and 27. And I don't know about you all, but most folks are not having premium increases of only 3 or less percent.
Right.
And so, I think a lot of times it seems like this is, we're like, well, this was great. You did this in 2022. Let's just call it a day. We don't rest on our laurels. And so we went out to RFP, a medical RFP in 2024. And this is where my story turns from all positive to less than positive. But I wanted to highlight specifically some incredible healthcare journalism that has kind of brought this story to life. So we wanted to go out to medical RFP because in part we recognized that the way to continue to, drive savings in our benefit, continue to leverage that data, is to ask and to challenge the status quo. But we learned a couple of things. One, Data is essential, but not enough of it exists. We can talk about like how New York, Indiana is eighth most expensive. If you look at Gloria's graph, New York is right now is number 7. We're close to 300% of Medicare. But what I can't tell you, even with the transparency data that exists out there, is how much we will pay. Healthcare is the only commodity that you buy without knowing how much it's going to cost. We wanted to make sure we also learned that we need to leverage the tools that are available in the marketplace to validate our assumptions. And Gloria is going to spend quickly talking about her tool, and her tool is one of them that we have used. There are other tools in the marketplace, and these assumptions are so important because insurance carriers are going to tell you how much money they're going to save, but they cannot prove it to you. And we are very much, I always say, people talk about being trust but verify. I'm more in the distrust but verify because the data doesn't exist to trust the assumptions. We also learned that the rights matter more than the rates in some instances. We spend a lot of time talking about how much things cost. But if you don't have the right to your data, if you don't have the right to manage your network however you want, if you don't have the right to design a benefit that works for your employees, it doesn't matter how much money you're going to save.
Mm.
And that is in part because of these anti-competitive contracting terms between providers and carriers will hinder transformation and choice. What happened to us is we selected Aetna. We're currently with Anthem. We selected to go with Aetna. And when we did, New York Presbyterian told Aetna that we are not allowed to keep them out of network. The hospital system came back and told us an ERISA self-funded plan had to keep them in network because that is the rules and the contract that they have with Aetna. This resulted in us actually staying with Anthem for 2025. I highly recommend you all, if you've not read the story, to go look at the story that Anna Matthews wrote through the Wall Street Journal, or any of the number of follow-up stories that were written about this. But the reality was we had done everything right. We had done an 18-month process and still found out that in the end, the hospital system could blow up our own RFP process.
And the hospital didn't tell you that when negotiations started? I mean, you were talking to them for 18 months, maybe not the whole time, but they should
That
have
is
said
not
that
the
right up front,
hospital.
right?
It's not the hospital. It's the insurance carrier. And the
Oh, I
insurance
see.
carrier believed they could remove them from the network for us. And in the
Oh,
end, they could not.
wow.
So I kind of share these are very high level stories, and I could talk about this for hours, similar to Gloria, in part because I'm really proud of the work that we've done. I could talk about our centers of excellence. I could talk about the different data items we've done. I could talk about our tiering. But in the end, I wanted just to spend the last few minutes before we hand it over to Gloria to talk a little bit about how as an activist employer, can help you all as journalists listening here today can figure out how to learn more and do more. And so first, there are so many free tools available to you. And I can't wait for Gloria to tell you a little bit about the SAGE tool. We have a website, 32bjhealthinsights.org. It is currently down. I don't know why, but it is currently down. But I highly recommend you all go there. There is a ton of resources on there, including different analyses that we've done in the New York metropolitan area. We are offering a conference. We have a conference, The Price of Power, Confronting the Hospital Affordability Crisis, on Thursday, September 19th in New York City. It is free. It is also virtual. So if you go to the 32bjhealthinsights.org, which will be working again, I'm sure, shortly, you can, because of course, technology always makes it hard. You can register for the conference. If you're in New York City, I highly recommend you come. We have multiple panels, policy and politics in the morning, and more the employer voice in the afternoon. We'll be talking about things from site neutral policies to a tool that we are going to be launching to help employers understanding their cost saving options, to also this contracting process that we went through in the RFP. We've got a whole, it's going to be great. And Zach Cooper, if those of you are familiar with him, he is the one who did the study that talked about how, as hospital prices go up, the impact it has to employer healthcare costs and employees and employers, and the bottom line of resulting in job loss. He will be the keynote that day. But then I think beyond that, beyond the learning, is as journalists, I challenge you, ask employers about their data and their benefits. Healthcare is often the number one or number two line item of costs for employers. Ask them, are they getting their data? How are they managing their benefits? I saw in the chat someone said, but employers aren't doing it, are saying they're okay with their benefits. I would say, like, do they really know? Are we asking employers the right questions? Are we saying, are you willing to take to include a high price? Do you recognize the cost implications of these high priced hospitals? And then on the same side is hold providers accountable for their role in the healthcare ecosystem. Oftentimes, and I'm not talking about like the actual doctors or nurses and the people on the front lines. I'm talking about the administrators of these provider systems. We oftentimes, I think, providers get a pass because they're the ones doing the healthcare, and absolutely the doctor should. But these administrators, these not-for-profit hospitals that I was at the beach on Sunday and I watched an airplane advertise two not-for-profit hospitals in the sky, and I thought, this is what our tax that they're getting tax exemption dollars for, is to fly airplanes advertising these hospital systems. And then the last
Wow.
piece I want to end with is that policy matters. Oftentimes employers, I think we talk about the benefits, but there is this intersection of policy and benefits that have to start to be continue to drive it. Gloria said it best. Employers, it's unusual for employers to be the ones showing up and having this conversation with the policymakers, but it's so important that we find other employers continue to stand together. It's and I would say I've become a policy wonk in the last 3 years in this process, because you cannot deconstruct benefits and policy any longer. And I challenge all employers and policymakers to bring them together. And so with that, I'm going to stop sharing and let Gloria spend just a few minutes talking about one of the coolest tools out there, including what you as journalists can use it for.
So before we do that, Gloria,
Yeah.
we have to go to questions. So
Okay.
I really want to hear about Sage Transparency. I just don't, we're running out of time. It's 1:48. So
Mhm.
maybe what we should do is schedule a time for you and I to talk, and then we can talk about how the Sage Price Transparency tool works. And maybe you could refer me to some other sources, and we could explain. Listen, journalists, this is what will help you. So in the meantime, I want to go to some questions. So one of those questions I saw you wanted to answer, is there only one hospital if there's only one hospital within a couple hundred miles, like as if you were in Alaska, then what do you do?
That's the problem, right? So when you have a monopoly in a market, they can charge 3, 4, 5, 600% of Medicare. There's nothing that an employer can do. So price transparency is great, quality transparency is great, but if you're the only game in town, that's not enough, right? Now you just know you're paying 600% of Medicare. So what you need is policy. As Cora was saying, there is now a direct link. They shouldn't be allowed, like any monopolies, shouldn't be allowed to just charge whatever they want. This is what we call an inelastic service. It's not like we can opt in to it, right? We all need it. And so we are proposing that there's a price ceiling. You can still negotiate under that price ceiling, but what should that price ceiling be is up for negotiation. Some states have put different percent of Medicare caps in place already. And to encourage people to be a network, they have a different cap, a lower cap. For example, Oregon, they'll say, okay, it's 200% of Medicare if you're in network, and it's 180% of Medicare if you're out of network. And so it encourages people to be in network, which is important because the way the benefit plans are designed, it's more beneficial to people if they pick something that's in network, because of their, without getting into like so many weeds, but basically they have more robust benefits if it's in network. So, there's nothing we can do. Employers can't do anything about it. They get
Yeah.
to charge whatever we want. We have that here. There's like some counties that have no hospitals in Indiana. Some counties have one, and they're serving multiple counties, and they are the highest price hospitals. And you can go on Sage Transparency and call them out, and say, wow, your prices are twice as high as, the rest of the state, and
Right.
apply pressure on them.
Right. Um, so yeah, we have to keep our answers
I mean,
short, but
sure,
I
yeah.
think you already answered this one about the 285% versus 254, and that was just because they could charge that, right? Before anybody knew that 254 was the average nationwide, they charged whatever they could, right?
That's right. Yep. They charged whatever they could. Anthem's president would come up to me, and he had a footprint all in 13 other states and say, Indiana's the highest price state. And I'm like, well, I mean, where's the data? Like, how do we know that? You know that, but you can't share that publicly. And the hospitals and the insurance companies sign a contract where neither one of them could disclose the rate to the employer, which is totally crazy. And we federally have gotten rid of that. But yes, that's what happened. It was inertia, that
Right.
kept our prices going.
Yeah. So Cora, here's a question for you. When you remove a large hospital system like New York Presbyterian, what about patients who need really specialized care, such as cancer treatment, that's only available in that one place? What happened with those patients?
Again, I think I'm really fortunate. I have a ton of hospital systems, and what we did won't necessarily work in, like the counties where they only have one hospital. But in a lot of these major metropolitan statistical areas, like I think about Houston, which also has a cajillion hospitals. I think about, Minneapolis, Florida, which I think has a hospital on every block. That there's a lot of places you can go where you remove one, there's going to be a bunch of other high quality hospital systems there. So I'm not saying you can't just do this willy-nilly. I understand that we're in a fortunate position. But the other thing is you have to have a commitment, I think, and a couple of things. One, you have to have a commitment to your membership. And I think employers have to have a commitment to the membership that if it turns out that New York Presbyterian is the only one who can treat a very specialized thing, we would do a single case agreement with that hospital. And Anthem, who's our administrator, would do the single case agreement because that means that there's nobody else anywhere. And that is a standard process within healthcare today. That's not actually that unusual. And I think it's a great example of when we talk about cancer, is there's currently a public fight happening in New York City with Memorial Sloan Kettering, a top cancer hospital in the country. They
Right.
publicly sent letters to members, to their patients, saying, we're fighting with Anthem. Call Anthem and tell them we have to be in network. And I want to say, like, look, believe it or not, I'm on the side of Anthem on this one. MSK is more expensive than other high priced cancer centers. And I think they'll settle because I think this is just a game in a lot of ways between the insurance companies and the hospitals, and this happens everywhere. But we as employers need to take the data. And as journalists, you need to take the data that's available and say, time out. You wrote a letter to the members saying, oh, you better call so we stay in network. You're already higher than everybody else, and you're asking for an additional price increase. What are you doing with that money? Because if it and like, are we actually using this, are you using your dollars correctly? If Medicare is a fair and reasonable benchmark, where are you against Medicare right now? And I think these are the questions that you as journalists and as you need to be asking employers these questions too, because employers I think often don't know, but the data exists out there for us to know that.
And the question to ask hospitals is, all that money, is it going to patient care, or is it going to general administrative expenses? Is it going to salaries of multiple administrators and here and there and everywhere?
And there's
Those are important questions to ask, because if it's all going to patient care, well, then you go, well, patient care. But if it's going to other things,
Mhm.
uh,
There's actually a
then
great
that's
tool.
not good.
I was going to say the
The
same
na
thing. Go,
the
Cora.
Yeah, I was like, there's a great tool. There's the
Yes.
NASHB tool.
Yeah.
NASHB stands for the National Association of State Health Plan. Nope.
Nope.
Okay, whatever it stands.
National Academy for State Health Policy.
Thank you. Okay, so totally did not get that right. But this tool is great because they have a component in the tool as the percentage of labor. Because one of the things you often hear is labor costs have gone up. All of these traveling nurses, our nurses' costs are what's driving these price increases. And they have shown that labor costs are not going up at the same rate in which prices are going up.
I'll put it in the chat for everyone.
Yeah, it's a fantastic tool. Again, lots of really great tools out there.
Yes, really, and I will get back to you on that, Gloria, on the price transparency tool, so we can help empower journalists to write about how that works and how to ask these questions of hospitals and other provider groups. One of the problems, though, that we've identified here is that if you're in a big city or a big metropolitan area, you're better off than if you're in a rural area where there's one hospital for multiple counties. That hospital then is going to have some market power to boost prices, and with no competition, no one's going to come back at them. But I did want to mention that our next webinar in this series from the Peterson Milbank Fund is about monopoly power of hospitals, and so that would be it's time to talk about that, because when big hospitals combine with other smaller hospitals, those smaller hospitals get the same market power that the bigger hospitals had, and that causes prices to go up and wages to go down, as recent research showed. So I don't see any questions here that we did not answer. Well,
Do you want
one
me to
person
show
asked, how do you...
Sage transparency for just 2 minutes?
Oh, go ahead. Yes, please.
Okay. So just in 2 minutes, I've got Sage Transparency pulled up. You can Google it and you hit access the dashboard. And this is an interactive dashboard that's freely and publicly available. We have over 4,000 hospitals loaded. That comes from the RAND study. And we have 4 other data sources. So you can, it defaults to Indiana, but you can pick any state and you can look up information about hospitals. It just defaults to Ascension Anderson because it's in alphabetical order. But if you pick Indiana, you can see it's got all these hospitals in there. And it just gives you some information. What is their operating profit margin? Outrageously high. What is their payer mix? How much commercial and what's their profit off of commercial, Medicare, Medicaid? How much charity care are they providing? And then comparative prices between national benchmarks, state benchmarks. Here's quality information, more quality from CMS, and a bunch of prices, and then who the legislators are that represent that hospital. You can compare hospital systems. So Ascension Health happens to be in a bunch of states, and you can see the prices of Ascension Health and why does it vary so much? And the quality varies. Some are high priced and low quality, and some are low quality, high priced. And it goes into some break evens and more quality information. There's hospital by state clinical categories. So if you want to search by MRIs or childbirth, endoscopies, you can narrow it down within a state to a certain region even. So as an employer, this can be really helpful, or even as an employee. State compare, policymakers really love this page because it gives state rankings on prices 9 different ways. We talked about that earlier. We added this is ambulatory surgery centers. So in addition to hospitals, you can see the price of ASCs can vary from 1,000% of Medicare to 73% of Medicare, with our state average being 241, the national average being 170. Also brand new.
An ASC, Gloria, is an ambulatory surgery?
Yep, outpatient ambulatory surgery center. So where you don't, like a knee replacement, where you go home the same day and you don't get admitted. There's medications. You can compare medication prices. And this is if you're a legislator tab. If you're a legislator, you pick what state you're in. If you're a state or federal legislator, and then who you are, you just pick somebody. I don't know. We'll just pick someone. It just changes. And these are the hospitals in their district. So what happens is, and it gives state averages for their state, how it's performing, how the health systems are in their state, and over time. So a lot of information and a lot of data here for folks. And thank you so much for allowing me to share that with you. I hope you find it helpful.
Thanks, Gloria. I appreciate that you were able to squeeze that in 2 minutes. And thank you very much, Cora. For you,
My pleasure.
to both of you, really, just a great presentation today. I'm sorry it was only for an hour, but I think we delivered a lot of great information, and you'll probably hear from a number of journalists now.
Please, anytime.
So our next webinar is September 24th, and you can find out more information about that at healthjournalism.org. Thank you all for joining us, and thank you, Cora, and thank you, Gloria. What a terrific presentation today.
Thank you, Joe.
Thank you all.